All right, so one of the big topics we want to talk about with our respiratory issues is tuberculosis, which is an active infection that patients can get. It's a really difficult one for us to manage as nurses caring for patients who have this type of infection. We'll talk more about that. So first thing we want to talk about is the pathophys of this. So it is an airborne disease, meaning that it is transmitted on those microscopic dust particles that kind of float around in the air. Very, very highly transmittable disease. So think about like when you're at home and you see sunlight coming in through a window, all those little dust particles floating in the air, that's what TB or tuberculosis can travel from person to person via, is those floaty little dust particles. So pretty scary mode of transmission. It can exist in the body in two different forms, an active form where patients have active infection, or a latent form. One of the things that tends to happen with TB is it tends to do what's called encapsulate itself, meaning that it's going to do this kind of thing right up here where your TB infected area tends to loculate or encapsulate, meaning it just kind of forms this nice little ball that can protect itself from outside intrusion. Outside intrusion being like antibiotics, which we're going to talk more about. But when patients have active infection, that encapsulated area can be prolific and grow and spread to other parts of the body. During the dormant or latent stages, it's just encapsulated. The TB is in there, but it's not actively spreading or actively reproducing. So patients can have both types of infections. It can also, it's primarily a respiratory disease, and most of the cases that we deal with are in the pulmonary system. They're in the lungs just like this dude. But there can be cases that are extrapulmonary. That usually happens when patients are immunocompromised. They can get TB infections in their liver or in their bones, things like that. But it can go other places, but it's not very common for that to happen. Etiology of TB is this bacterium, the Mycobacterium tuberculosis. That is the infectious pathogen that causes tuberculosis in patients. It is what's called an acid-fast bacillus. Acid-fast bacillus is a way that we can identify it through microbiology. So acid-fast is one of those tests we do. Thinking back to micro, remember you guys gram-stained things and you can make them turn purple, which was kind of fun. Acid-fast is another one of those types of exams where we can assess what does the bacterium look like to identify tuberculosis. In the US, it's a very specific population that tends to have TB infections. It tends to be more at-risk populations. Prevalence in the underserved communities and also in prison populations, which are underserved and highly concentrated. So we can see TB outbreaks in some of those areas. You can see them at like homeless shelters where one patient can transmit to a large group of people pretty quickly. Also in prisons where a new inmate who gets admitted to the jail system can spread this amongst an entire cell block area pretty rapidly. So these are common tests that are done when patients start to encounter some of the high density services for those populations, especially prison populations. Healthcare workers are also at super high risk because we work with these people. You know, these populations seek healthcare and we are exposed. So we are also in one of those high risk categories. Sadly, there's also currently a resurgence of TB in the world because for a couple of reasons. One, we have more HIV positive and AIDS patients in the world than we ever have before because we have really, really good antiretroviral treatment now. So AIDS patients can now live full lifespans, but they are still immunocompromised. And because of that immunocompromised state, they are at risk for infection that may or may not infect other people. So that decreased immune response really can cause problems for them long term. The other big scary problem is we are starting to see a lot of multi-drug resistant strains of TB, meaning that multiple antibiotics, it's not even like VRE, which is vancomycin resistant bacterium. These are multi-drug. So there There's a lot of different lines of therapy that are not effective in treating this. And we even have cases of what we call pan-resistant, meaning that bacterium, that strain of tuberculosis, is resistant to all antibiotics. So we have no effective treatment for those cases, which is a little bit terrifying when we talk about an airborne disease. So looking at that public health-wise, this is from 2016, so a little bit old data, but in 2016, there were 2.5 billion TB infections in the world with 10.4 million new cases every year. And here's the part that's a little bit frightening, is since the 80s, we've been pretty effective, since the 90s, we've been pretty effective at decreasing the overall number of cases present in the world. We've been treating TB and trying to eradicate it, which has been great. But in the last several years, we've seen a plateau start to happen. And this is really around those pan or multi-drug resistant strains of TB. So it's evolving to combat our ability to treat it in patients. It's also a very difficult type of bacterium to treat. So the symptoms we're looking for in our patients, they're going to complain of fatigue, so a general malaise, which is really nonspecific and sometimes really difficult to assess because we kind of hear, oh yeah, I've been tired. It's like, okay, join the club. Welcome to nursing school. I've been tired since I started this program, right? So fatigue can be a thing, malaise, weight loss leading to anorexia can also be a thing. But the big three are persistent cough, non-productive persistent cough, low-grade fevers, and night sweats. If patients start stating those three, alarm bells in nurses' brains go off and we start to get super concerned. When we do our assessment on these patients, there's not a lot of physical exam findings that are going to cue us off that patients are positive for TB. Their respiratory exam could be very normal. When you hear their cough, there's not going to be anything productive about it, so it's not going to be necessarily terribly concerning. But every time they cough, they're shedding bacterial load. So that's a mode of transmission, is all of that exhaled air from their lungs. So we have to be super careful about these patients because most of our diagnosis comes from our interview. It's a lot of subjective findings that we get in our patients. For screening, what we do, so it exists in the way we identify this is a few different ways. One is screening, and you guys all went through screening just as part of nursing school. So first line screening is our PPD tests, so our skin tests. A positive skin test means you got induration. Induration's like that thickening of the skin. So if you've ever gotten like a cut or a deep bruise or something when it's inflamed and it feels dense compared to the skin around it, that's induration. And erythema meaning redness. If it's negative, it looks like what all you guys have probably got, which is where after you insert it, after a few days, nothing is there at all. And that's good. That means that you do not have exposure to TB. What we're starting to shift towards in the healthcare community is doing quantiferon gold blood testing to see if there's been any blood exposure to TB. So that's becoming our new standard because there are some reliability issues around our skin testing. And then if either one of those screenings tests positive, then we do a chest x-ray as kind of our second tier of screening, where we're looking for the actual loculated sections within the lung that are going to tip us off that this patient may have either active or latent TB. But we will see those loculated areas on x-ray. For patients, if we can't do our screening, because most patients we're not going to be doing screening on. A lot of this is for healthcare providers. For diagnosis, when patients present to us, we're looking to diagnose disease. And by we, I mean not nurses, but physicians are looking to diagnose disease. We're going to be testing patients. So we are going to get sputum cultures. And sputum isn't like oral mucus. It's that phlegmy, hacky stuff that comes from your trachea down in here. We're going to be getting cultures of that and testing it for those acid-fast bacillus. When patients have 3 positive AFBs, or acid-fast bacillus tests, we consider them to be positive for tuberculosis, which is now it's like we're all terrified, all the bad things have happened, and we're pretty sure we're taking it home and we're going to have TB the rest of our lives. Very rarely has it happened. I've had 3 exposures to TB in my career, and I've always been notified about them by the public health department like a month after I took care of that patient. So I was like, oh, wonderful. That's super helpful. But I still have a negative skin test, so I don't have any active infection. I didn't contract any disease. So your risk of catching disease from patients is actually quite low, but we do want to be very careful to protect ourselves in those environments as well. So some of the nursing diagnoses that we do want to be really careful of for our TB patients. One is risk-prone health behavior. Words. So risk-prone health behavior really speaks to the transmission and how this can spread amongst a community. So if patients aren't protecting their airway or trying to manage their cough very effectively, that is risky health behavior for transmission of disease. So we do need to be very careful of that. Deficient knowledge around transmission and treatment are 2 areas that we really specifically address with TB patients. Fatigue is also one. These tend to be long-term infections in patients. And think about the last time you were sick. You were tired while you were fighting off the infection that you had. Now imagine if you had to do that for 9 months while you were getting treatment. These patients get very, very tired physiologically from fighting off foreign infection in their lungs. And then risk for disturbed personal identity. So as part of having an active TB infection, everybody who comes in contact with them has to be wearing an N95 mask or a respiratory mask that's very highly effective. So it can be really frightening if everybody who encounters these patients has to have that level of personal protective equipment in place. So they can really start to feel psychosocially not great about the whole situation. The medical plan is we want to treat the active disease. For latent TB, we don't really do a lot for that because they're not actively shedding bacteria with latent TBs. It's really the active disease, which is the phase of the disease cycle that we're really concerned with. So for active disease, we give 4 different drugs for a long, long, long time. This is 6 to 9 months of continuous antibiotic treatment, 4 antibiotics for a very, very long time. This gets scary. There's also some of these that do very weird things to the body. So rifampin, for example, turns all body secretions red. So tears and in the ocular mucosa can be red. Saliva can be red tinged. Urine can be red. So those can be very concerning symptoms, and we definitely want to educate patients that that could be a thing. The other problem with these are all some pretty heavy-duty drugs. They can cause ocular and liver toxicity. So they can damage those organ systems just from taking those medications. So we want to counsel patients to protect those organ systems as much as possible. That means things like avoiding alcohol. We don't want to tax the liver any more than we already are with the medications that we're prescribing for those patients. Here's the scary thing. Here's where it gets really frightening. Back to the public health, because TB really is like, for nursing, it's a public health issue first and foremost, and it's a recognition of risk. So putting patients on the proper isolation as quickly as possible in the hospital setting. But 75% of patients with drug-resistant TB, so this is any of these antibiotics, any one of these antibiotics aren't effective. Of that, not very many actually get to completion of treatment. So only half of 25% that do complete their treatment, only half of that 25% that did all 9 months of treatment actually become cured. meaning they don't have any latent TB left in their body. We've cured the infection. So we do not have a very high success rate in treating this disease, especially when we get into the drug-resistant strains. That's why we're starting to see that plateau of cases worldwide. It's a pretty frightening one. So for nursing interventions, our independent nursing interventions, which are the things that we can do without a physician order, that we can promote health in our patients, first and foremost, isolation. If you suspect that a patient has TB, so they start telling you about how, oh, I feel feverish overnight and I just have had this cough that won't go away. Good enough, we are isolating you, which means a negative pressure room, which is a room that sucks the air out of the room and blows it out of doors. So it creates a negative pressure inside the room, meaning we're not going to have bacterial load traveling under the doorway or out the door to contaminate care environments. And N95 masks. As a care provider, mandatory at all times if you're in a care environment with a TB patient. Also for all the visitors that go into that room, they have to all wear that level of protection so they don't become secondary infections for this type of, TB. Big teaching opportunities for patients, especially around cough hygiene. So we do want to teach them coughing into their elbows or into their shirts so that they're not actively projecting bacterial load into the air on dust particles, which can then transmit to other patients. And then antibiotics. So you guys already know about antibiotic hygiene and management. We need to teach patients, take the full course, don't stop when you start feeling better, all that kind of stuff. But usually people only take antibiotics for like 7 to 10 days. These patients are taking it for like 7 to 10 months. So much, much longer course of treatment for antibiotics. And they have to be disciplined in completing the entire course, or else there's a very high risk that they can promote a drug resistance in themselves for the strain of bacterium that they're contaminated with. The other big one around nutrition and education for this kind of teaching stuff, check out the link here for this medication compliance. TB is one of those kind of rare and few diseases where the public health department actually has the authority to imprison people and force them to take medication because of the risk of spread within a community. So there's a funny little clip about a person in Arizona who the public health department came down on him pretty hard. Feel free to check that out. Then our dependent interventions, we're looking at our diagnostic studies to confirm proof of infection and medications. So the 4 big medications that patients are going to be getting. So as part of our implementation, the first thing we want to do is actively intervene. We don't want to be passive about how TB presents in patients. That means isolate immediately if you have even the slightest suspicion for TB. Let somebody else tell you it's okay that we don't isolate these patients, but first and foremost, do the isolation and protect yourself and the population you're working around from potential infection. That means negative airflow room, N95 masks for everybody, and airborne precautions. Those 2 interventions equal airborne precautions, and that has to be in place for these patients. These patients don't have to be confined to their rooms. They're going to go to other parts of the hospital where they're going to get testing to verify their TB in the infection in their lungs. When they leave their room, they can wear a surgical mask to prevent the kind of transmission of those airborne particles from going all over the facility. So that's an appropriate thing for them to wear when they're out of that negative pressure environment. But if we go into that negative pressure environment, we need to wear the N95 masks. Antibiotic therapy is a thing, and then all is the sputum cultures. We're looking to get 3 sputum cultures that are positive for AFB in order to confirm diagnosis for tuberculosis infection. These are the N95 masks. These ones we call the duckbills because, well, you can kind of see why. And these are the other kind that we tend to see out in the community. These both come in different sizes. So as nursing students, you guys are not to take care of TB rule-out patients or anybody on airborne isolation. The reason is these are sized based on the shape and size of your face, and the occupational health department of the hospital that you're working in or facility needs to verify and fit test you for a type of mask. Guys or ladies with a very narrow face, if you have facial hair, we live in the spacesuits. It's called a PAPR hood, which is a positive air pressure respirator hood. It's not the whole thing, it's just this part up here. And this is an air pump that pumps air into this device, so there's actively air getting pushed out of the hood. That minimizes our risk of infection in that device. So those are the different ways that we can protect ourselves from an active TB infection. For our evaluation, we want to know what do we expect to happen as a result of treatment. So how do we know if the disease has reached its resolution? So have they completed the full course of antibiotics and there's no other transmission to other people in their family or in their community? Do they have normal pulmonary function? We may do pulmonary function tests or PFTs to measure respiratory capacity after TB infection so that we know whether that's normal or not. Absence of any complications, so we don't want to see that respiratory disease spread to other parts of the body during their course of treatment. And then no transmission to any of their family members or anybody they're in close contact with. Once they meet all that criteria, then we consider their disease to be eliminated. All right, on to the next one.